Here is your ear. Okay, so here's the middle and then the inner ear. So sound waves travel through the air, and then they cause vibrations, and those vibrations are carried inward through the anvil shape. Okay? And then it's connected to the auditory nerve, and then the brain interprets what you're hearing. So we have this membrane here, the tympanic membrane, which is usually thin. This protects us from toxins, from insects going in there. So as long as your tympanic membrane is intact, then no bugs can enter. Bugs, however, of course, can enter this part. Okay, I had an ant enter my ear one time. I was, I think, 6 or 7 years old. It was there all night. I can hear what it was saying. I couldn't sleep. And my older brother John, finally came to my rescue. He took it out, and then I tortured it. First problem is hearing loss. There are two types of hearing loss. We have conductive and we have sensory neural hearing loss. When we say conductive, that means it's usually caused by an obstruction. Something is preventing the sound waves from entering the middle ear, or the inner ear, sorry. So a few causes are earwax. That's the most common cause, actually, especially in the elderly. Or we have otitis media, otitis media, right? The ear infection, or otosclerosis. Sensory neural hearing loss is actually damage to the nerve now, either to the cochlea or the vestibulocochlear nerve. Again, conductive hearing loss caused by obstruction. That could be a functional or a mechanical obstruction. Mechanical would, of course, be earwax. Functional obstruction would be a structural disorder in somewhere in your middle or inner ear. Something's wrong there. Could be inflammation, meaning an infection, an ear infection can cause swelling and edema, correct? So that causes a functional obstruction in your middle or inner ear. Sensory neural, however, is because this is now damage to the nerve. So this is more caused by toxic exposure, usually to industrial or occupational exposure. Let's say you work as a um, landscaper, right? Or you work at the gun range, for instance. Or let's say you work with concerts, concert venues where they have really loud speakers, right? So anything that exposes you to high decibel sounds for a number of years without ear protection, then that can cause sensory neural hearing loss. Or some people are very unfortunate to have both. They have both conductive and sensory neural hearing loss at the same time. So how do you know someone is deaf? Okay, so here are assessments. Chart 59-3, speech deterioration, fatigue, indifference, social withdrawal, insecurity, suspiciousness, Have you noticed that in your elderly, if you have elderly members in your family, when they get deaf, they ruin relationships, right? They get, because what are you talking about? You know, are you talking about me? Okay, they see you talking, and then when they glance at you, and then you giggle, and then all sorts of things come up develop in their mind. What are they doing? They're talking about me, right? So this can so this can cause um disruption in relationships, right? They can ruin relationships. People can get divorced, okay, or at least fight, okay, over these. My in-laws are both deaf. It's the most hilarious scenes you can witness whenever I hang out at their place. Okay. Yes, but he can see. You know, he's only one eye blind. Yeah. Yes, but he has hearing aids. He can hear when he wears them. Prevention, of course, is, you know, proper ear care. Did you know that we need a professional to remove earwax? We actually do. Okay. Yes, we should periodically. Yeah, they have instruments that can, yeah, that it can safely remove earwax. Because, you know, what do we use at home? Q-tips, right? And of course, what will Q-tips do? We'll keep pushing, yeah. And then now, I noticed that one time I was in college, I was in class, and I laughed so hard, and then I felt something tickle that came out of my ear, and then I looked in, and I picked it up. It was a huge ball, like it was quite, yeah, a big ball of wax that came out. I said, wow, where did this come from? It came from my ear, just came off, just you know, just rolled out. I don't know how that happened. I should have kept it.
Maybe the ant was sitting there and pushed it out.
Oh no, the ant was long dead. I made sure of it. I kept it alive for a week. Yeah.
Oh.
I dismembered it one limb at a time. Yeah. So here are risk factors for hearing loss. So prevention, of course, is implied. Management, of course, the depends on the cost. So if your hearing loss is from conductive type, of course, we clean your ear. Okay, we treat the infection. All right. We give ear drops. We can irrigate your ear. But if it's sensory neural, there's really no treatment for that. Unless it's some kind of cancer, for instance. Let's say you have a tumor in there. So yes, we can treat that. However, sensory neural loss usually is just treated with hearing aids. That's all we can do because the damage to the nerve cannot be undone. 59-5, chart 59-5 is how we communicate as caregivers. So this is not only for the nurse, but all caregivers, and not only us, but also the family. They could also use the same techniques. So this is definitely a select all that apply question. Now, whether you use hand gestures, what's the volume of your voice should be, how you position yourself when you talk to the patient, or other means of communication. Here's one for patients who can read lips because they do compensate. So over time, they learn how to read lips. That means you have to face the patient when you talk to them. And there should be adequate lighting wherever you're facing the patient. This is kind of hard. The last bullet is kind of hard because in clinical, we still do wear masks. Okay. Some hospitals stop using masks altogether. Let's say Montefiore, St. Barnabas. I'm not seeing nurses wear masks there anymore. Where? Which one are you? Moses or? Okay. Well, they're not wearing it a whiler. So I can see everybody's faces. So cerumen impaction, this again requires a professional, okay? You can be prescribed Debrox, to eardrops so you can moisten the ear. We do have instruments that have a camera and they sell it online. Just be careful with those though, because you're not really, because you could push that sharp instrument and then there you go, you bust your eardrum and then that's it. You created a different problem now. So be careful about those sharp, pointy instruments, okay, that you don't perforate your eardrum. Then you'll have permanent hearing loss.
Hmm.
Warm water should always be used for irrigation, never cold. Cold water irrigation will actually cause involuntary eye movements. Have you tried that as a child? Yeah, you can put ice water into your ear and then your eyeballs will just move involuntarily. Like your eye will do this and you have no control over that. And you say, this is crazy. And then we take turns doing it. So foreign bodies can be entered in there, tissues, cotton balls, okay, especially by kids. So you can put peas, beans, pebbles, toys, or beads in there, right? And then probably come out later in your adult life. Again, attempts to remove any foreign body or foreign object can be dangerous, right? So leave it to a ENT. You have insurance anyway, so go to a professional. Okay. I'm just trying to find because there's only one condition where the surgical pre and post-op care is mentioned. Okay, it's here. Mastoid surgery. So for pre and post-op care, if the patient undergoes either tympanoplasty, tympanectomy, meringotomy, meringoplasty, it's the same. Okay, so we have a chart. Okay, chart 59-7. So some antibiotics may be in the form of an eardrop. Okay, so how do we administer eardrops? Where do you position the patient? Okay, opposite side on the unaffected side, and then how do you how do you pull the pinna? In an adult, how do we do it?
Down, oh, down. No, because the thing is higher, lower when it's an adult. Down and back. Down.
Okay, so if it's an adult, because the ear canal is pointing up, so you have to pull it up. Okay, and in the child, since the ear canal is pointing down, you have to pull it down. Make sense? Again, let me repeat. In an adult, the ear canal is pointing up, So you have to pull it up so you can see it and then administer the eardrops, and then opposite for the pediatric. So the patient will be positioned in the opposite side, unaffected side. Then after you instill the eardrops, the patient is asked to move their head back and forth, okay, forward and backward to make sure the eardrops go all the way, all around the ear. Then for surgery, so besides antibiotics, is it any different from the eye? Where is the ear? It's still inside your skull. So the precautions, is it any different from eye or brain surgery? Exactly the same. So same activity restrictions. Can you get the ear wet? No. So any surgical site, do not get it wet. So there will be a packing there. There will be a cotton ball packing. You can change it if it gets soaked with drainage, then replace it with a new packing. Now, these are normal popping and crackling sounds up to 3 to 5 weeks after surgery. That is normal. There's also temporary hearing loss after the surgery. Now, the reason for that is because there's a packing in there too. So that will also obstruct your hearing. Report, just like with the eye, report excessive or purulent drainage. Purulent means there's pus, right? Okay. We don't call it pussy drainage. We call it purulent. Okay. Because you can say, pussy, but then when you write it down, okay. So just like with the eye, do not get the operative ear wet. For how long? 2 weeks. You can shampoo your hair, but the ear must be covered. But if you're not confident, then don't take a shower, just like with your eye surgery. Remember the pressure will go into your ear. However, if you have to blow your nose, because sometimes you cannot avoid it, always blow with both nostrils, through both nostrils and with your mouth open. Okay. Okay. It's possible. Believe me.
What about traveling on airplane because of the ear pressure?
Okay, very good. Air travel will also be so same. So if you can't get your ear wet for 2 weeks, then there will also be no air travel for 2 weeks, or any other vehicle that has pressurized cabin. Okay, so besides airplane and submarine. Okay. Yeah, we'll never know. Maybe you're in the Navy. I don't know what kind of job you are. Yeah. Yeah, my nephew is a chief, what's his title?
Yeah.
Chief Petty Officer. Yeah, he's in well, he's retired now. Yeah, he spent 20 years in the Navy. 23 years, actually. And then he retired at 43 years old. And then now he joined the State Department. He's in Switzerland. Okay, last two. First is vertigo, and then we'll finish with Meniere's disease. Who has had vertigo? You've never had vertigo? No, when you're playing with those games, when you turn around like that?
Yeah, yes.
Okay, so that's vertigo, right? Okay. But this one, though, is not caused by a game. Okay, so you just experience vertigo. So it's usually a symptom. Okay, so vertigo is not a primary disease. This is a symptom of another disorder. So usually it's a manifestation of either Meniere's disease, or you can have some other neurologic condition, for instance, a stroke can cause vertigo as well, or head trauma. So vertigo is also called motion sickness. So I don't have to tell you manifestations. Your world goes around, then you get a headache, and then followed by nausea and vomiting, right? Management usually treated conservatively, treated with anti-motion sickness medications, dimenhydrinate or meclizine. Meclizine, also called Antivert, that's over the counter. Other non-pharmacologic intervention, of course, is to increase fluid intake, avoid alcohol, avoid smoking, and low salt diet also will help with vertigo. Side effects of these medications, dry mouth and drowsiness. So here's Meniere's disease. One of the manifestations of Meniere's is vertigo. There are 3 manifestations here, among others, of course. So when we say vertigo, that's always going to include nausea, vomiting, correct? Okay. So vertigo, nausea, vomiting, and dizziness are all together when you have vertigo. Then there's tinnitus, ringing of the ears, and I mean constant ringing of the ears, not like we have occasional ringing of the ears, right? We don't know what causes that, but it goes away. But these patients, it's steady, it's persistent. And then there is unilateral hearing loss as well, meaning hearing loss on only one ear. So that's Meniere's disease. There is no cure, unfortunately. And the most debilitating part of Meniere's is the vertigo. How can you work when you have vertigo, constant vertigo? Are you going to be disabled? Yes, because you can't, because it will affect nutrition too, right? I mean, how can you keep down a meal, right? And you're constantly dizzy, so you're going to be vomiting whatever you eat. So Meniere's is like, so it's chronic, it's a chronic condition, no cure. You have periods of remission, meaning you have periods wherein you have no symptoms, and then you'll have attacks. So when you get these attacks, of course, you cannot go to work, cannot go to school. You are bedbound for a few days until the symptoms go away. So it's a sad chronic disorder. Management usually is just symptomatic. There is, again, no cure. So all we do is give you medication for the vertigo, diet, and fluid intake is encouraged. So low sodium and increase fluids, avoid alcohol, avoid smoking. And here's your dietary guidelines, which is mostly like heart cardiac diet, like low sodium. However, they also encourage you here to limit MSG, monosodium glutamate, is also known to trigger attacks. So fruits and vegetables, plenty of fluids again. Limit coffee, tea, and soft drinks. Basically, limit caffeine. As already mentioned, MSG, as already mentioned. Here, this is only if you're getting a diuretic, because a diuretic can be prescribed to these patients because they believe that when you have attacks of Meniere's, you have increased fluid buildup inside your inner ear. So you'll be given diuretics to decrease that, and then that tends to help with the alleviation of symptoms. Also avoid aspirin and aspirin-containing medications. This can increase tinnitus and dizziness. So how do we treat the vertigo here? Because vertigo is the number one complaint again, and is the most debilitating part of having Meniere's flare-up. So remember, there are 5 types of antiemetics. Have we discussed those under post-op management? You don't remember? Okay, fine. So we have several antiemetics. That's not in this chapter though. That's under the post-op chapter right here. Chapter 16 under nausea vomiting. Let me just show you the table. Right here, chapter 16, table 16-2. You have 1, 2, 3, 4. Now, ondansetron, so some of them are repeated. So we got ondansetron, scopolamine, hydroxyzine, dimenhydrinate, promethazine. Actually, there's 6. Okay, and you have different choices here because they have different actions. For example, metoclopramide, this one is good for acute nausea. Phenothiazine, also acute nausea. Promethazine, acute nausea. Dimenhydrinate is for preventing nausea. Same also for ondansetron. So serotonin antagonist like ondansetron, as well as dimenhydrinate, are for preventing nausea. So in case you want to, if you need to decide, let's say all 6 are ordered for your Meniere's patient, right? So how do you decide which one to give when they complain of nausea? Well, it depends. What is this nausea? Is this acute, or are you trying to treat nausea that's already present, or are you trying to prevent nausea? So that's how you choose which drug to give. And you teach the patient the same also. So that's for antiemetics here. Again, we give multiple antiemetics, okay, because the nausea here is pretty severe because of the vertigo. Now, for severe attacks, the patient will have to be given sedatives. So we will give them Valium, diazepam. Diazepam is not really an antiemetic, but have you ever been nauseous when you're asleep? Can you be nauseous when you're sleeping? No, because nausea is a conscious sensation, correct? I mean, you have to be aware of nausea, right? Because otherwise, if you're sleeping, then there's no nausea, you're sleeping. So that would be an option. For severe episodes of the vertigo, we sedate the patient, give them Valium, diazepam, and then they go to sleep. No vertigo, no nausea, vomiting. Okay. But of course, do you want to sedate the patient all day? No, they have to eat, right? So that's when you give the antiemetics. So what will you give before the meal? They don't have nausea yet. Can you give the ondansetron to prevent nausea? Yes. Okay, so that's what I mean. Okay, so when you go to that table, you give medications appropriately. So you choose the one to prevent first, and then they can eat. Okay, they can finish a meal without vomiting. And then later, when they do get acute nausea, then you give either promethazine, metoclopramide, okay, so the other medications. Here's the diuretics options. Again, diuretics are only given during attacks. Thiazide, potassium sparing. Surgery, again, pre and post-op only. So the same as the chart we saw earlier under tympano, no, after myringotomy, right? I mean, you know where the chart is. That's about it. BPPV is quite common. I'm not testing this. I'm just, making you aware that this is a frequent complaint. So sometimes patients have vertigo, but they don't have Meniere's, meaning this just occurs on its own. We call that benign paroxysmal positional vertigo. And some patients can be evaluated for this. They come in, we work them up for making sure it's not a stroke, but they find a CAT scan or MRI is negative. They diagnose you with BPPV.
That's
Yeah, but this is, of course, that's why it's called benign. I mean, this is harmless. Okay, so it happens to the best of us. But that's not part of our